Hello, my name is Sean Graves. I'm a certified instructor coordinator and a member of the Training and Education Committee for the New York City Regional Emergency Medical Service Council. I'm also joined today by Mr. Monty Posner, who's also an instructor coordinator and a member of the committee. The objectives and goals of today's presentation is to present BLS providers who operate within the New York City region, a review of the update of the general operating procedures, a review of the protocol changes and areas of emphasis, as well as a review of changes to the appendix. You should note as a BLS provider that these protocols will go into effect January 1st, 2022. The first part of this discussion will deal with the general operating procedures. There is a new definition of excited delirium that appears inside of the general operating procedures. There's a new transfer of care section that deals with the transfer of care between ALS and BLS providers. And as a side note, the GOP went from 34 pages to 25 pages to make it more concise. The definition of excited delirium is as follows: a behavioral syndrome that's comprised of a combination of delirium, psychomotor agitation, anxiety, hallucinations, speech disturbances, disorientation, violent or bizarre behavior, insensitivity to pain, elevated body temperature, and abnormal strength that's often associated with stimulant use. Further discussed down in the GOP is the area of transfer of care between ALS and BLS providers. When we have ALS and BLS resources that are both providing care to the same patient, it is permissible for ALS to transfer care to BLS as long as the patient meets all of the following criteria. Number one, the patient must be hemodynamically stable. The patient must be able to follow simple commands. The blood glucose level of the patient must be above 60. The patient may not have received any medications or treatments under ALS protocols. The patient is not expected to require ALS intervention, and there's no reports of acute coronary syndrome either ongoing or within the last 24 hours. If an ALS and BLS provider are providing care for the same patient, the ALS and BLS must or shall transport the patient if there's ever a replacement of an advanced airway, or the patient is having their ventilations assisted, the patient's currently in cardiac arrest, or there's a concern that the patient might deteriorate further down the line, or if the paramedic on scene feels that there's a need for additional assistance during transport. When this occurs, ALS and BLS are caring for the same patient. Each unit shall complete an EPCR and document the care provided. So now we'll dive a little bit deeper down into the protocols, and we'll point out some areas of concern, especially for our BLS providers. So what you're seeing on your screen right now is the non-traumatic cardiac arrest protocol for the pediatric patient. You're also seeing on your screen the non-traumatic cardiac arrest adult patient, and that hasn't been changed. But what we did was we took these protocols and we mirrored them as closely as possible to each other. Studies have shown us numerous times that the most effective thing, regardless if we have a pediatric patient or an adult patient, is high quality early CPR. So when we talk about the priorities, the things that we're doing for somebody who's in cardiac arrest, again, pediatric or adult, is what should we be doing initially for that patient? What's going to make the biggest difference? And again, we've been shown time over time again that that's, again, early high quality CPR and early defibrillation. So pretty much these protocols are the same. There are minor differences. So if you look in like section 3 here, you'll see that applying the AED to a patient's bare chest on the adult protocol, the wording is a little bit different there for the pediatric patient in terms of the appropriate sized pads or the appropriate sized location for that patient. But other than that, these are pretty much the same. The priority here is delivering that high quality CPR, whether this is an adult or a pediatric patient. Another point of a change was in the respiratory distress and respiratory failure protocol. As most of you probably know, the American Heart Association recently updated their guidelines. There weren't a ton of changes that really affected us as BLS providers, but one of the points that did is something that kind of reflects our early education. We know that children typically breathe a lot more quickly than adults do. And what they found was giving a child who is either in respiratory failure or completely apneic, but still has a pulse, would be best done by providing a ventilation at 20 to 30 breaths per minute. So this kind of works out to be 1 breath every 2 to 3 seconds. So you'll find that all throughout the protocols, both for the ALS and the BLS protocols, but that's definitely something to keep in mind. As we go in the same protocol, respiratory distress, respiratory failure, pediatric patient, we'll notice that there are some key points of considerations that are especially concerning for BLS providers that are handling these type of sick kids. So number one is bradycardia. We've learned early on in our EMS education that bradycardia is a very ominous sign when it comes to dealing with a sick kid. Children are rate dependent. So once a child starts to go into bradycardia, we have to start to think of it to ourselves that cardiac arrest might be one of those things that are imminent. We've been taught for a lot of years that blow by oxygen is an acceptable form of giving a pediatric patient some oxygen, some supplemental oxygen, but it's actually been shown to be an inadequate way of doing so. Instead, what BLS providers should be doing if they're going to be giving a patient supplemental oxygen is choosing the appropriate device depending on how that patient's breathing. So if you have a patient who just requires some supplemental oxygen, a nasal cannula or a non-rebreather would be appropriate. If you have a patient who's more in that failure or apnea stage, a bag valve mask would obviously be more appropriate to provide that supplemental oxygen. Another note is for a tachypnic child. So tachypnea, just as a review, is fast breathing. And whenever we have a child with fast breathing, a lot of times we think about the etiologies being respiratory. But we have to think back to our early education a little bit and think about maybe this is something that has to do with the endocrine system. As most of you know, early onset diabetes usually does affect children. And when we're presented with a child who is tachypnic and fast breathing, we have to sometimes associate those signs as being maybe something else. Might be a good idea to check that patient's blood sugar just to see whether or not they're hyperglycemic. So the next protocol we're going to deal with is anaphylaxis, severe allergic reactions. You should note that this protocol encompasses both your adult patient population and your pediatric patient population. So the first part that we're going to talk about is epinephrine in this protocol. Epinephrine is a great drug for anaphylaxis. It's our first line drug for patients that we are assuming are having anaphylaxis, so that severe allergic reaction. Just something that you should note about the doses. So the doses for epinephrine on standing order, so the things that you're allowed to do for as an EMT is going to be a maximum of 2 doses on standing order. So now, if you have a situation where you had CFRs who were on scene already before you, and they had the ability to give an epinephrine autoinjector, that would actually be included into your dose. So it says here a maximum of 2 doses on standing order, including any dose that might have been administered by the CFRs. So we're going to include those doses in our count. As we go a little bit down in the protocol, something that's actually pretty interesting is that we know that sometimes anaphylaxis is associated with respiratory conditions and wheezing. And we've been for many, many years giving patients like that albuterol. Another drug that's now been added into the BLS formulary is ipratropium bromide. So ipratropium bromide is now part of the BLS scope of practice, and it's given similar to that as albuterol. In fact, it's mixed with albuterol when we give it. And the max dose is going to be on standing order 3 doses. It's very similar to albuterol, right? So everything that we've learned with albuterol, we're just going to kind of mirror that with ipratropium as well. And it makes sense because we're going to be mixing these medications together. So a common theme as I start to discuss the dosages of ipratropium bromide and repeating the doses of albuterol is that you're going to see me keep saying that you can repeat as necessary, but the max dose is 3. Okay, so we'll look at the dosing here. And again, just remember we're in the anaphylaxis, severe allergic reaction, both adult and pediatric protocol still. For the adult patient, you're going to give ipratropium bromide, gives you the concentration there, 2.5 milliliters. That's 1 unit dose. You're going to mix that with 1 unit dose of albuterol. So in essence, you have a patient, right, who's having anaphylaxis and they're having some respiratory issues and they're wheezing. We're going to go ahead and we're going to break out that albuterol, and we're going to also give ipratropium. We're going to mix both of these drugs together inside of the nebulizer, and we'll give that to the patient. This can be repeated as needed, but the maximum would be 3. So those mixes together 3 times. Pediatric patients, that's where things differ a little bit. If you are 6 years old and above, it pretty much mirrors the adult dose, as you can see here. It's a 1 unit dose of ipratropium bromide and 1 unit dose of albuterol. Repeat as needed, up to 3. So we're mixing those drugs together. Younger patients, a little bit different. Younger patients, we're actually going to take half of the unit dose of ipratropium bromide and the full unit dose of albuterol. So you can half of that. And as you can see here, it says 1.25 milliliters. It's 0.5 the dose. So that's half the dose of ipratropium mixed with the full dose of albuterol. So we're going to give that 1 unit dose. Okay. We're going to mix those together and we'll repeat as necessary for a maximum of 3 doses. So for adult and pediatric patients, right, we have combined the anaphylaxis protocol. So it also makes sense as a segue looking at this protocol now. This is a different protocol. We're now out of anaphylaxis. We've now found ourselves in the asthma / COPD / wheezing protocol for both the adult and pediatric patient. And you really need to start to understand number 7. So let's just discuss number 7 briefly. It says for adult patients and pediatric patients, and then there's a parenthesis here who's kind of defining what a pediatric patient would be specifically for this protocol. And we'll see why later on in the key points and considerations. An age that's equal to or greater than 2. So this protocol is designed for patients who are equal to or greater than 2, or any patient that we have that's equal to or greater than 18 months with a history of albuterol use. So it's super important that we're asking the parents or the caregivers about the possibility, has this patient, especially if they are meeting that age of less than 2 but greater than 18 months, have they ever used albuterol before? Because that might change the way you're actually treating this kid. So for those patients, we're going to administer the ipratropium along with the albuterol together, okay? So it's not going to change basically what we just learned in the anaphylaxis protocol. These medications are going to be mixed together and administered. So when we look at the adult protocol, again, very similar to the anaphylaxis protocol, 0.02% ipratropium bromide, it's 2.5 milliliters, that's 1 unit dose. That's going to be mixed with 1 unit dose of albuterol and given to the patient. And you may repeat this twice for your maximum dose of 3. Pediatric patients, again, just what we had repeated in the anaphylactic protocol, but we have to, again, repeat this here, is that they're 6 years old and above. We're going to give 0.02% ipratropium. That's going to be that 1 unit dose mixed with the 1 unit dose of albuterol, repeat as necessary, max dose of 3. But if we find ourselves with a patient that is younger than 6 and meets the criteria for this protocol, you're going to half the dose of ipratropium. So we're going to only be giving the 1.25 milliliters, and we're going to mix that with the full unit dose of albuterol and give that repeat as necessary for a maximum dose of 3. So we were in number 7, and as we go down a little bit into that protocol, we'll start to transport. There's never a reason why we should stop transport to give this patient these nebulized medications, right? We're going to be doing that while we're getting them down into the ambulance and while we're transporting the patient. So we never delay. So that's why it says here, initiate transport after starting, your first albuterol and ipratropium dose. Do not delay transport to complete the medication administration. That's something we absolutely should be doing en route to the hospital. Then it says here for adult patients, this is number 9. And why is it only for adult patients? Sometimes people ask this, is because of the equipment size. So, if you have an adult patient that meets your equipment and you have CPAP, your agency does have CPAP, this is what you would be using this for. So number 9 says for adult patients with persistent respiratory distress, begin continuous positive airway pressure or CPAP therapy. Gives a reference here for Appendix P, which you can look that up. And that's if available, right? Because we know that not all BLS agencies do carry CPAP, but if your agency happens to do that, that's definitely going to be a good consideration for somebody who's having asthma, wheezing, COPD. Number 10 deals with epinephrine for asthma, right? It's a little bit different. When we have somebody who's in this severe respiratory distress and they meet the criteria of the asthma / COPD or wheezing protocol, and we get down to here, the dosing of the epinephrine or the amount that we're going to give is actually a little bit different than it is in anaphylaxis. As you can see here, it's only 1 unit dose on standing order. In anaphylaxis, it was 2. Here it's 1. So that's something that you definitely want to take note of, okay? So if you have a patient who's less than the age of 9, okay, so your 8-year-old patients or any patient that's less than 30 kilograms, which is roughly 66 pounds, we're going to give them that 0.15 milligrams of epinephrine, that standard pediatric dose, right? If they're in very severe respiratory distress. If we happen to have a patient who is equal to or greater than 9 or equal to or greater than 30 kilograms, which is again about 66 pounds, we're going to give them epinephrine at 0.3 milligrams IM. That could be done during either, if for EMTs, that could be done by either drawing up a needle and syringe, or we could give that by auto injector, depending on what your agency is carrying. So always refer back to your agency's operating procedures for giving epinephrine. All right, so now as we go into the key points and considerations, again, what protocol are we in is the asthma, COPD, wheezing, adult and pediatric protocol. We have mentioned before that that protocol is really designed for children above the age of 2, right? And it's their first episode of wheezing. So maybe this has never happened to them before. The likelihood of this actually being true asthma is pretty low. More of the time, this is what we call viral bronchiolitis. It's the inflammation of the bronchioles that's causing this. And there's really no role for some drugs. Now, since this key point is also written for ALS providers, we see things like racemic epinephrine, which is not part of the BLS protocol at all. So we're just going to kind of ignore that. But it's no role for the drugs that we give also. So things like albuterol, the ipratropium bromide, or again, ALS providers, steroids. We're not going to be giving that. So that's not something that if we have a kid, again, who's less than 2, the most likely cause of their wheezing is going to be this viral bronchiolitis. So how do we manage that? The management of viral bronchiolitis includes things like supplemental oxygen, which is great for hypoxic patients or anybody who's having difficulty breathing. For ALS providers, they'll consider things like intravenous fluids for severe dehydration. And for all providers, right, it's us assessing the patient and identifying whether or not they need ventilatory support. Do I need to use a BVM? Do I need to actually ventilate this patient? Is always something that we're going to be concerned with. I had mentioned also before in that criteria that, you know, we sometimes will have a patient who's equal to or greater than 18 months, so not 2 yet, but they've had a history of albuterol use before. So during our history and physical exam, parents or caregivers are saying, no, he or she's, they've been prescribed albuterol before. Well, if we have a patient like this, or we have a patient with a strong history of family history of asthma or atopy or eczema, these might be situations where albuterol could be administered following by monitoring that clinical response. So in other words, that means, is the child getting better? Right? These are definitely some considerations to take home and just take a note of, depending on the type of patient that you end up encountering.